which must be why he's standing up there.
I was told to do that, so I'm doing what
Okay.
I'm told.
Thank you very much. I'll hand it over to Spiro.
I'm really frightened. I'm
No,
more frightened
no.
about his introduction.
No, it's my pleasure.
I literally don't know what he's going to say.
It might be recorded, so I have to be careful what I say. No, it's my pleasure to introduce my friend and colleague, Marie Scully, who came all the way here from London, England to give a talk. I've known Marie for many, many years. We kind of grew up in the field together, sitting in the back of the room, and now we've gotten a little closer to the front. So it's been kind of a fun ride. She's a really sharp person, really dedicated, an expert on congenital and immediate TTP. So I'm very interested to hear what she's going to tell us today. So with that, I'll turn it over to Marie, or I'm sorry, Professor Scully.
Oh. Well, firstly, thank you, Spiro. Thank you, Claire. And thank you for the invitation to be able to come to the US Patients Day. I really do appreciate it. And for all your kind words. Now, I've been given a brief of 30 minutes plus 15 for Q&A. I'm going to keep going until you all leave and they turn the lights off. And once we're all finished and happy, then you can pop down to around the corner where they do free drinks from 5:30 to 7. Have you seen that? But be gentle, because Claire's probably got an evening ahead that will mean that you need to.
Yes, we have the armadillos.
Nice and steady and be sensible. So I know you've seen this picture already, and this is my interpretation, and I've got a bit of a twist on it. So you know about von Willebrand factor, which is a very important protein in all of us, present all the time. And von Willebrand factor has to be broken down before it can be active. Now, who in the audience is Italian? Anyone Italian? Good. Anyone married to an Italian? Anyone like to be married to an Italian? So I like to keep things simple. And the simplicity and the reason that I'm showing you something from Lady and the Tramp relates to spaghetti. But what I'm going to say next may upset all Italians. So if you envisage that von Willebrand factor is just a great big long string of spaghetti, and we have to break it up. We break, well, not normally in the kitchen, but in life, we need to break up the spaghetti. And that's what we've got the scissors for. And those scissors are Adam's 13. And the reason that we need to break it up is we want to generate all these different sizes, because otherwise it just doesn't work. So when we break them up, the spaghetti's in the smaller parts, thanks to Adam's 13, the scissors, platelets bind to the different size strings. And those different size strings with platelets, gentlemen, when you shave and you cut yourself, the first thing you do is you put pressure. And these little smaller parts of von Willebrand factor with the platelets go to that and prevent you from bleeding. Now, in other situations, if it's too deep, you need other clotting factors. So essentially, the smaller parts of von Willebrand factor with the platelets, they plug the hole. So that's the normal situation, and then we've got TTP. So our scissors, the Adam's 13, are closed. They can't cut the spaghetti. And the reason they're closed is because we've got antibodies preventing them acting. And our nice string of multimers now has this new bit called ultra-large multimers that I'm sure you've all heard about. And these ultra-large multimers bind loads of platelets. They can't stop binding platelets. So when you all come in with your platelet count of 3,000 or 3, and with us medics that look after TTP patients say it's fine, it's not that you've only got 3 platelets in your body. They're just all in the wrong space. They're all bound to the big long bits of spaghetti. And these block small vessels. So we've got nice red cells who can't get through, and then they become sheared. And that's when we see the fragmented red cells under the blood film. So I'm going to talk first about the these different aspects of therapy today. So what are we doing with those therapies? The plasma exchange is replacing the scissors, the ADAMTS13, and the steroids and the rituximab are trying to get rid of the antibodies so the scissors can open back up. I've added in here some cases that I thought you might quite like to hear because it makes it feel a bit real. And these are all real patients that I've looked after over the years. The first one is a 45-year-old Caucasian lady who attended her local ED. And she presented with left-sided facial weakness, numbness. Her face was drooping, she couldn't speak properly, and it resolved within 15 minutes. The team there thought she had a TIA, gave her aspirin and a CT scan, and were going to send her away to go to the TIA clinic. She then, while in the emergency department, had these funny visual auras and quite a bad headache. And they then thought she just had an atypical migraine episode until she had an epileptic fit. So they did some blood counts, and I think these will all be quite reminiscent for you. Anemic, thrombocytopenic, raised LDH, troponin was raised. But in the ED setting, there are a number of different reasons that you can have these blood counts, but the team did query a diagnosis of TTP. And at that time, the patient was completely stable. She had a normal Glasgow Coma scale, which is a measure of brain function, a normal blood pressure, and her saturations were fine. So she was transferred to us, and during that time, she became increasingly confused, agitated, couldn't speak. Her Glasgow Coma scale had halved, and she required intubation and ventilation. She did very well. The point of this particular case is to show we intensively used to treat patients here, and sometimes twice daily plasma exchange, high-dose steroids, and started rituximab early. But after a few days, and this was pretty common in the past, we used to see a drop in the platelet count. Does that matter? Well, yes, because she started getting more neurological symptoms. Restart the plasma exchange, intensify the plasma exchange, increase the steroids. And she did absolutely fine. So these were the mainstay of therapies. We've got our plasma exchange to give ADAMTS13, and we've got our steroids and rituximab, which made a big deal even at that stage to get rid of antibody. But there was a massive but. Despite the improvement in care, despite the improvement in diagnosis, since the 1980s, the mortality hadn't improved and was still up to 20% in even the best centres. Drop and they get more symptoms. That really tells us the disease is terribly active and we've got to up the game again. And then there are those patients whose platelet count just doesn't shift and it stays low for days and days and days. And with each passing day, the risk of problems increases dramatically. And those problems can also include patients dying. So I've got two more cases, pretty comparable. Young women, one Caucasian, one Asian, completely fit and well, both with a reduced Glasgow Coma scale, so their neurology was not normal. They had other symptoms which would suggest that they had some other ongoing infection. Maybe, maybe not. Case 2 required 10 plasma exchanges, and case 3 required half the number of plasma exchanges, even though looking at the patients, their presenting features were very comparable. So case 2 had a much higher troponin level, a worse creatinine, but they needed half the number of plasma exchanges to case 3. Why was that? It was since the introduction of caplacizumab, and both those patients were in the studies at this time. I thought you'd enjoy this picture. So There's always a story. So Kaplan was originally derived from llamas. When I was on a beach in the south of France this year, that sounds so extra, doesn't it? But it's true. I was at the beach and this kid had one of these plastic things where they could put them around their body, and it was a llama. I made my daughter chase around the beach to get a photo, but incognito, because the parents would have thought it was a bit weird. So this is a llama from the south of France. And it's very important, the technology, but even more important for patients, what does caplacizumab do? Well, it binds to the sites on the pasta, von Willebrand factor, where platelets normally bind. So we don't have those big clogs of platelets. We've got Kaplan sitting in their spot. And that's why we see reduced microthrombi formation and a quicker time to platelet normalization. This is from the original, what we call the Hercules study, and it was the randomized phase 3 study that we need for a drug to become marketed, for we get authorization that it demonstrates a benefit. The most important thing for me from that study was this graph. And the reason that it's important is red is placebo, blue is patients that receive Kaplan. Otherwise, they had completely standard of care comparable. I put a circle between days 4 and days 20. 50% of patients that are going to die from TTP die during these periods. And they die because of not incrementing their platelets or because they keep getting these exacerbations. And with caplacizumab, initially it's comparable. The platelet increment is comparable between the two. And then in patients not receiving caplacizumab, it becomes quite sluggy and it takes a time for them to get back together when the platelet count is normal, both in the Kaplan arm and the placebo arm. But that period in that circle is very dangerous. So apart from the risk of dying during that period, which is not something that any of us want to talk about, there is the risk of these recurrent exacerbations, and it keeps patients in hospital longer, they get sicker, they require more therapy. But the outcome of this, in patients that receive caplacizumab, they needed a third less plasma exchanges, which means less blood product in FFP. It is a blood product. They had a significant reduction in the number of days in intensive care and also the number of days in hospital, going from about 14 days to about 10 days, which is that is significant. So this is the current protocol for the treatment of patients with acute TTP. And I have put in here, it does depend where you live. And there are a number of barriers that, you know, are often beyond our control, but this is what we would class to be the standard of care, which includes plasma exchange, caplacizumab, and immunosuppression with steroids and rituximab. Now, it doesn't mean that other therapies are not needed. It means this is the basic standard of care acutely. There's been a lot of discussion about when to start caplacizumab, the effect of caplacizumab causing bleeding, which it can do. So our pasta, the levels of it become very low. So essentially, patients receiving caplacizumab are in a highly bleeding state, but the patients are also very thrombotic. So it kind of does even itself out. A many number of countries have put all their data set together. I'm obviously going to talk about the UK because I'm from the UK and I know it the best, but numerous countries have, and everyone's come up with the same opinion. The earlier you start caplacizumab, a la the trials, the better the outcome. I don't know why that keeps jumping. It's very irritating. In our patients, we had a look at the whole cohort when we had access to caplacizumab before it was marketed in the UK. So there was a lead time where we had to get it into hospitals, people had to get familiar with it. For those patients who started the caplacizumab later, they had the worst outcome. And it wasn't anyone's fault. Like I say, it was just access to therapy. And for those that started it as soon as the diagnosis was made, and in the UK we confirm with an ADAMTS13 that's very low, they had the best outcomes. Now, there are bleeding risks attached to the use of caplacizumab. They are rarely serious, they are manageable, and we can manage it with therapies that are not ununique to being used within TTP treatment, or we can reverse it if it does look particularly severe. I said in one of the meetings earlier on, there is a group of us internationally, and that group has expanded, but looked at terminology, which sounds a bit tedious, and it is, except we need it to understand what we're trying to achieve. And the terminology for acute TTP is thus: we can get patients, in the red, the platelet count, into a clinical response or a hematological remission. That we can do quite quickly, and it's the first thing that we have to aim for, which we can now that we're using caplacizumab within the treatment pathway. But then the next stage is a complete ADAMTS13 remission or complete remission. So there is two things that we're trying to manage during the acute TTP episode. Conversely, the reason that we now say that TTP is a chronic condition and requires lifelong monitoring is this situation can happen at any time to anybody. The platelet count remains completely steady, but then your ADAMTS13 activity level starts to decrease and gets to a certain point, if left untreated, would result in acute TTP. Who likes coming back in to have a central line, plasma exchange, high dose steroids? And so why don't we give you something to prevent it? That's the rationale for giving rituximab prophylactically, electively, preemptively. There's a whole load of words that are used, and we've been doing it for quite some time and successfully. Now, it doesn't mean that there aren't issues. There may be issues, but the lion's share of patients respond well to it. And not only do they respond, they're not unwell while they're having the treatment with regards to TTP. Our French colleagues had a look at the data in giving patients elective Ritux or not. In this first graph here, the summary of it is, and this was retrospective, 2 patients died in the relapsed group, i.e. who did not get elective rituximab. So you think, I've had TTP, I'll be fine next time I come in. The clock's reset. It's like you came in the first time, all the risks exist. And this second graph is also very important because it tells us something that we had already highlighted previously. There's about 50% of patients who will at some point need elective therapy to increase their ADAMTS13. Conversely, there's 50% of patients who will never need it. How do we define those patients? We can't. The only way we can do it is with monitoring the ADAMTS13. So there's immune, and I'm going to now just change tact a little bit and look at congenital TTP. This slide is only meant to represent that this is the gene for ADAMTS13 that has all these different exons. There's 29 exons in the gene. And the top bit was all the mutations that we had in the UK, but that was before we found all the additional mutations since whenever this paper was written. The point is that there's no specific hotspot in the ADAMTS13 gene that we can just look at. We have to examine the whole gene. Saying that, there are cohorts of patients that we now know carry the same mutation. So, for example, primarily Caucasian patients who present later in pregnancy are more likely to have an abnormality in exon 24. We've got a group of travellers in the UK, all of whom have the same mutation. We've got a group of patients from Africa and from Pakistan who again have very similar mutations. So we're understanding more and more literally every month. I am dealing with the UK data. Again, I don't apologise for it because I'm going to add in some other countries, but I do know it very well. But it's more the story I want to tell you, not where it comes from. What we found from our cohort of patients, and this paper was a few years ago, is that about 40% present in the neonatal period or the childhood. And 42% of patients present in pregnancy. So that was a big change a few years ago. We always thought that congenital TTP was only in young ones. It's not. We've got this second cohort in women who are pregnant and develop TTP. So it kind of goes like that. And then we've got this bigger cohort with women. So where are all the men? Given it's an autosomal recessive condition, which should have a 1-to-1 male equal female. So there are men with congenital TTP that have not been diagnosed. And then we have a cohort at that time of patients of late onset congenital TTP. Ethnically, it's very diverse. And there are a number of triggers. So we know pregnancy and congenital TTP will trigger it. We know infection in childhood or vaccination can. But importantly, 27% of the patients had no clear trigger. So they kind of had this system where their platelets would just go up and down. And that was more likely in the young ones, but it still affects adults. So that's the acute presentation and a bit about the epidemiology. And then we realized that we had in the patients a normal platelet count, but they were having terrible symptoms. So these are known as non-overt symptoms. Headaches, awful. They weren't just, I'm tired, I've got a headache. These were going on for days. These were exacerbated at weekends, if they drank a lot of coffee. Tummy pain, central, not associated with any specific organ. Lethargy, they weren't tired. They were doing 12 to 15 hours a night and then needing an afternoon nap, and it wasn't a joke. And when we checked their urine, about 20% had proteinuria. It was at that time that we altered our treatment regime with regards to plasma infusion. It was a discussion. It was a trial with the patient. Do you feel better if we do this, if we make it more frequent, if we increase the dose? Yes, I do feel better. I haven't had any symptoms. Or no, I'm fine till day, whatever. So we've changed it again. But importantly, what we also found is that all those patients that have proteinuria, that's a bit of protein in the urine that's telling us the kidneys are starting to get irritated, it went. And the risk of having stroke significantly reduced. Concurrently, when we published this data, the International Registry also published their cohort of patients. The most important fact from that paper for me is that 50% of patients not on ADAMTS13 prophylaxis by the age of 40 will have a stroke. That is really high and very, very significant. So we've had two main options. We've had plasma, FFP, and in children, certainly in the UK, and I know in patients in the States and other parts of Europe, we use this intermediate factor VIII concentrate that contains a little bit of ADAMTS13, but works really well in the kids. When we give plasma to patients with congenital TTP, This is what we're seeing as a maximum amount of ADAMTS13. It's about 30% absolute maximum, and that's giving every week. So it's not very high when the normal range is above 60%. So let me tell you about one of my patients. In 2017, a 36-year-old gentleman came to the emergency department. Funny enough, he was Italian. He was with abdo pain and upset and said he'd had a dodgy frozen pizza. Have you ever known of anyone having a bad frozen pizza? But he told the emergency staff that he'd had these recurrent episodes of TTP. I didn't know what he was talking about. He wasn't on any treatment. He'd been in the UK for 6 years. He hadn't bothered to get any help. So he, as per the protocol, was sent over to us and went on to the phase 3 study for recombinant ADAMTS13, but on demand. And he got standard of care, which was plasma. Anyway, he got better. He was fine. We then tried to put him into the prophylactic arm, which again was standard of care, Octoplas, plasma, but he had terrible infusion reactions. And we don't often see them with Octoplas, but he really couldn't take it. He had terrible, terrible reactions. So he only had that twice. And then we switched him over to this intermediate product, similar to the CoA DVI that you guys use over here. We use 8Y. Anyway, he was a nightmare. He sort of turned up every 2 weeks when he could fit us in, working and traveling, of which he did both. And he never had any symptoms. Where I've put here symptoms, headaches and extreme tiredness, this was a retrospective admission. And then we had the pandemic. For my patient, this was probably a good thing because he couldn't travel. He was stuck at home. You weren't allowed to leave your house during the worst of it. His only way to get away from his wife was to come to UCH every Friday morning. I joke you not. He was so compliant for that first 9 months. Anyway, so we decided that it would be a good opportunity to put him into the study. So the first 6 months was standard of care, so he's 8Y. Now, the pandemic did get better, and there were periods where we were allowed to move and travel, of which he did. And he went away, and he came back in a real pickle with acute TTP. And of course, he couldn't have Octoplas. He did get 8Y, but it was the time for the crossover at 6 months for recombinant ADAMTS13. And I mean, he was fine. He did really, really well. Then we all had another 1 or 2 lockdowns, so he was compliant. And then in 2022, he was out of here. He did the Caribbean with his wife. He did Italy, see his mum and dad. It was goodbye, au revoir, UCH. Thanks for the time that we had together. So he missed loads of treatment. He wouldn't listen. He then presented with an acute TTP episode, and this is where it becomes serious. His platelet count was reduced. He had all the symptoms. He did have an infection. And then he just complained of these very mild neurological features, which you could have just passed off. But he had an MRI of his scan. He's got multiple strokes in his head. And his blood pressure was raised. Don't feel too sorry for him. He's absolutely fine. He is the most compliant patient in my clinic almost. And he's had no ill effects from the strokes, thank God. And in fact, last week, I said to him, you know, he knows he's a nightmare. We talk about it frequently. I said, it's been a journey, you know, how do you feel? You know, would you change being on recombinant ADAMTS13? He said, it is the best thing ever. He's going, you know, professionally, he's going to a very senior position. He's learned to give the drug himself, so can do it at home. It's been a big change, but it is a journey, and TTP is a journey. And sometimes you need to work with us and we need to work with you. So what about this recombinant ADAMTS13? Well, it feels like two centuries ago when we first did the phase 1 study, where we give one dose to see how high we could get the ADAMTS13 in a group of patients. Now, you remember when we gave patients plasma, it went to about 30%. In congenital TTP patients, it went to 100%. And it wasn't just one patient. You know, that was the median level, 100%. Lovely. And it seemed to last longer. Brilliant. One dose. Let's get on with the trial. So that was 2017. And then finally this year, we published the phase 3 study. Now, as I said, we need phase 3 studies to be able to present to the regulators. But this even was above our expectations. It's only 18 months of treatment and the extension study continues. But it is not a blood product. If any of you watch the BBC News on your app, and some Americans do, you will know that we've been hit with a terrible scandal that's gone on for many years called the Infected Blood Inquiry. And that's about using blood products over using recombinant products, which are not blood-based, not for TTP patients. So it's not a blood product. It's given quickly. In the trial, there were no acute episodes in patients receiving recombinant ADAMTS13. I would say that in patients receiving plasma, it is protective of acute episodes or more frequent acute episodes. It reduced the number of those non-overt symptoms. And honestly, we hardly see any of them in the patients these days that are on recombinant. And we've got quite a lot of patients on therapy. There was no antibody formation. Now, what that means is when you have a recombinant product, which is the normal ADAMTS13, and you're giving it to someone whose ADAMTS13 is not exactly the same because they've got mutations, there is a risk of forming antibodies. And it was a worry when we started doing this study, and we did not see it. We did not see it in any patient. And 2 of our patients have been on it for nearly 8 years. That's because it took so long to finish the study. Takeda. When you can get a dig in, you get a dig in. So what else did we see from the study? Well, here is how high the ADAMTS13 goes and how long it lasts compared to plasma or the factor concentrates. And it's ubiquitous amongst all the patients. It just goes high and lasts longer. And these are all the other symptoms that we don't want to see on a day-to-day basis. And they all were in favor of recombinant ADAMTS13. Ignore the creatinine. That included 2 patients. And so you can't really make anything from that. So the future. There's a number of possibilities for the future. And they involve not using plasma exchange, which can only be a good thing. I think the main reason patients are scarred from acute TTP episodes is line insertion. Is that right? And then obviously reactions if they have reactions, but it's the line insertion is, you know, traumatic. So the proposal is multifold. Firstly, there's the Mayari study, which has just stopped, but we do use this in patients. And in particular, and Spiro certainly was involved with the publication, in specific groups of patients, for example, Jehovah's Witnesses. In the past, those patients died of acute TTP. We had nothing to give them. And now we have, and it does not involve blood products. So we can use caplacizumab, steroids, and rituximab. Now, the trial's finished, but we're waiting for the readout of the results of this to demonstrate the efficacy of this specific protocol. But then there's the future. So the recombinant ADAMTS13 that we've discussed in congenital TTP, we're now doing a phase 2b study in immune TTP. Can you imagine getting 20 mils or 10 to 20, depending on your weight and the dose we give you, rather than 3 to 5 litres of plasma in an exchange. And not only does it work, it will make the levels higher, but we've got to overcome the antibody. So we've got a little bit of work to do. So this VITA study is looking at recombinant ADAMTS13 at 2 doses given twice a day, steroids and rituximab. But then the future, depending on what the results of the phase 3 show, is that we have a number of options. So we've got recombinant ADAMTS13, we've got caplacizumab. We still need to optimize our immunosuppression. There is no doubt about that. But we know what we have works, and we need to get rid of the awful part of therapy. So the future is bright, but it does take a certain amount of courage. Can you imagine the day you first went into hospital with acute TTP? You had some mad woman saying to you, you've got this terrible life-threatening condition, we need to do X, Y, and Z to you. And by the way, could you go into a clinical trial of a drug that we don't know how it's going to work? Can you imagine it? Well, patients do it. I do spend a little longer than that, you'll be pleased to know. But it's a lot to take in. You've got a new condition that's frightening with intensive therapy, and then we want you to go into a clinical trial. The patients have done it over and over and over again. So if you do get asked to be part of research, not necessarily in the acute setting, anytime, even in the clinic, please participate, because we have made massive strides. And I say we, it's an international effort, and we can only continue to do it if we have patients at our side. I'm happy to take any questions, and I'm sure that we've got questions for you as we go along. So please forgive us if we keep asking the same thing. It's been an absolute pleasure. Thank you for your attention. Well, that stumped you, didn't it? You've asked all your questions today. Have you got any questions? Seriously? So that's the recombinant ADAMTS13, and whether we're going to be able to have it for subcutaneous use. Oh, thank you. I thought you were going to tell me, yes, we are. I've got it here, but you weren't. No. Is there someone from Takeda here? Is Takeda here? Takeda. When can we get subcut? Oh, okay. I thought you'd studied it. I thought it had been studied. No? Soon as we know more. But I mean, that, you know, again, it's options, and it will make it easier. So it's certainly being developed, it's been investigated. So I couldn't give you a timeline, but it's there. Any other questions?
There's a question. Oh, so sorry. Go ahead.
We've seen is about the 27 for times 216. And now we haven't gotten below 10, which has been really good. His baseline. If he was to get it twice a week, would that elevate him even more and prevent some TIAs? Because we have a lot of TIAs.
So how we in the so firstly, the first job is to get everyone on the drug. And I've heard about all the issues with regards to your insurance and the politics. So let's get everyone on the drug. At the moment in the US, it's primarily for 2 weeks, and that's being adapted by your clinicians. In the future, I think we will adapt the dose. I don't know what form it's going to take, and it's going to be patient specific. And I think we've got still a lot of work to understand what the baseline level before the next dose is, and what the peak is, what we want to achieve. We probably don't need 100% of ADAMTS13, do we? But I think that's just, again, there is more pressing issues generally, but I think you're going to be seeing Senthil, aren't you? Where is Senthil? He's gone for a sleep, has he? Oh, no, you're there. He knows what he's doing. He'll have it. You're seeing, isn't it that what you said you're going to see Senthil? Are you going to be a patient of Senthil or Marshall's? Oh. Just give it a little time. You know, the fact that we've got recombinant available and being used for patients, let's just see how we go with it and how we can adapt it. But I think it'll be sooner rather than later. There's nothing fixed. I think it will depend on the patient. And as been discussed throughout the day, it's not just all about ADAMTS13. We've got to correct all the other factors that are going on in patients. In immune TTP, the genetics of immune TTP. So yes, we've looked at that, and there is a HLA association for risk in Caucasian patients and protection. And we've done some more work looking at something called GWAS, that's genome-wide association studies, but in Caucasian patients. And we have found foci. But essentially, the biggest risk is attached to this HLA region. That'll tell us more about why the disease develops, rather than we wouldn't be able to use that to necessarily say you're at risk of TTP and you're not, because it's not common enough. The really exciting thing is looking at non-Caucasian patients. And there's been a massive barrier to that for a number of years, not because of the patients, but because of the normal controls. So when we have X hundred patients, we need many thousand normal controls, which we've not had access to until now. So from September, I have a youngster starting who will be looking at the GWAS, the genetics, but only in Afro-Caribbean patients. And that's big, and we're going to obviously get other confirmatory cohorts. So I'm putting a plug out for the US TMA to get confirmation. So we do it, and then we need confirmatory cohorts. So French, and hopefully if the American team will play. The importance, so that's the way you've got to do genetics. I'm not big on genetics, but I know what you've got to do. Why is it so important? Nobody has looked at autoimmune disease genetically. So it will be the first autoimmune disease to be looked at, and it won't be the same as Caucasian patients. I think it'd be really exciting. He's got 3 years to do it.
Is that youngster the one that received the USTMA UK TTP registry scholarship at the last ASH meeting?
One of
that
them.
Gave the presentation. So it's a great way that we foster new and upcoming junior faculty.
Yeah. Yeah, Matt. It's quite an expensive endeavor to do the genetics. Is very expensive. So we've been very lucky to get a big, no, it's not that big. We've got a grant to do it. So that it's not that big, I promise you. The university gets most of it. So I'm hoping that we will find some really important information, particularly in the kind of more, African-American, Caribbean, very autoimmune. African will have a different set of findings. I think it would be amazing. And it needs to be an international collaboration. Please. Huh? What? Collaborating? Oh, I thought you meant doing the GWAS. I thought, you've never said a word. I can't hear you. I'm a definite hope.
Sorry, you have a lot of research in prediction and relapse, and just this genetic study as well. Now, the race conversation has been part of this meeting as well.
Yeah.
But in the UK,
Yeah.
there is much more equitable access to care. How does that fit in with the genetics of the disease versus the equitable access to care?
Okay, so yes, there has been a disparity in what we found between across the pond. So we do not see an increased relapse rate in Afro-Caribbean patients, and about 40% of our patients in the UK are Afro-Caribbean. You do see an increase. I mean, it is what it is, and there's a whole host of factors for why that may be the situation. In the UK, and I can only speak about the UK national health system because it's all I know. I don't know the American system. I don't know, do you know the American system? It's so complicated. You've got 51 versions, right? But everyone, if you walk in and you have TTP or you have acute leukemia or everyone gets the same standard of care. Conversely, it doesn't mean every hospital has the same standard of care, but there is protocols in place such that everyone should be getting the same standard of care. So everyone gets plasma exchange, they all get Caplivi, they all get steroids, they all get, a single room with its own bathroom in what looks like a hotel, not a hospital. So it doesn't matter shape, color, size. We've got a number of patients who are very disabled and, are really disabled, actually, not just very, that have got terrible previous neurological abnormalities, nothing to do with TTP or severe autism. They all get the same. So we don't have any difference in relapse rates because if you drop your ADAMPS, everyone gets elective retux. I don't have to fight with medical insurance. Thank goodness. I don't think I could cope with it if I had to do what you guys have to do. But it's taken years to get to that point. So it's easy for me to sit up here, all blasé about how great it is in the UK. That has not been something that has been there all the time. The equity of care is because we are a highly specialised commissioned service. So the National Health Service cut off X amount of money to make sure all our patients get the same all over the country. And that was the remit of us having it, is that there was no difference between London versus Newcastle. I pay a lot of tax, I know that, but I don't, who you do or we do? You pay more tax or we do? How much do you pay? I don't want to know. I bet mine's more than yours. It feels like it anyway. So I might be paying for the TTP service in my taxes, yeah. Oh, sorry. Yeah. Forget about the.
I answered the questions online about where to find clinical trials and put the link in the chat. And then there was a question if the new treatment referring to recombinant MCS13 was approved. And so I provided the information that's approved currently for congenital in the US and as indicated being studied for immunoacquired. So we're good.
It is my pleasure. Thank you very much.